And what I'm really going to talk more about is central pain or brain pain that's coming from the central nervous system more so than the nerves or from the knee. And the characteristics of that pain are different than the characteristics of pain that's coming from the knee or coming from the nerves. And the treatments that you have to use are quite different as well, because there are treatments that work in the brain, not treatments that are working in the knee or working on the nerves. So let me go through each of these different types of pain. So nociceptive pain is the scientific term we use when pain is coming from your knee. There's something wrong in the peripheral part of your body, in a joint, in a bone, in a ligament, in a muscle, and that pain is occurring because there's something wrong in that area of the body. There's either damage or inflammation of that area of the body. If you have that kind of pain, you can actually localize the pain very well. The location of the pain will be consistent from one day to the next or from 1 week to the next. And there will also be a consistent effect of activity on that pain. Most types of pain in your knee get worse when you use your knee and get better when you don't use your knee. So if you have nociceptive pain in your knee, you will be able to localize it fairly well. You'll be able to show with one finger exactly where in your knee it's coming from. And you'll be able to say, my knee always hurts after I walk more than 2 blocks or after I climb 3 flights of stairs, because the pain is occurring because you have overused that damaged or inflamed area of the body, and that area of the body is sending a signal to your brain, stop doing that, you could be hurting yourself. Now, nerve pain has been known forever. Nerve pain is when there's either a pinched nerve or a damaged nerve. And I keep forgetting to put this on my electric guitar slide, but the nerves would be comparable to the cord that is going from the electric guitar to the amplifier. Is that if you cut the cord or you pinch the cord or you damage the cord, that is a theoretical cause of pain. And that is essentially nerve pain, is that there's something wrong with the nerves throughout our body because we have long-standing diabetes, because we developed the herpes zoster, because we have a pinched disc in our back or a pinched nerve in our wrist, and we develop either sciatica or carpal tunnel syndrome. But this is nerve pain. And nerve pain has its own unique set of characteristics. Number one, nerve pain will usually follow the distribution or the pattern of sensory nerves. So most types of nerve pain will be primarily in your feet and your hands, because that's where nerves end, and that's where the pain starts, is at the end of the nerves, not at the beginning of the nerves. So most types of nerve pain will be in what's called a stocking glove distribution, i.e. will be felt worse in the hands and the feet. And then as it progresses, maybe people will have nerve pain that moves into other areas of the body. But most types of nerve pain is either in a stocking glove distribution or it is in the distribution of the nerve that is being pinched. So if you have a pinching of your median nerve as it goes through your wrist, that's called carpal tunnel syndrome. And you will only have pain and tingling in the fingers that nerve goes to. You won't have pain and tingling in all 5 fingers in your hand. You'll have pain and tingling in this side of your hand, because that's the side of your hand that the median nerve goes to. If you have sciatica, because you have a nerve pinched as it's coming out of the bottom part of your spine, you'll have radiating pain down the back of your leg all the way down into your foot, because that's where that nerve goes. But again, nerve pain can be distinguished from nociceptive pain both by the location and by the characteristics of nerve pain. People will often feel it's burning, it's tingling, that they feel electrical shocks and things like that. Those are the characteristics of nerve pain. But this third type of pain has really only been recognized in the last couple decades or so, and this would be the type of pain that our research group has been most prominent in teaching the rest of the world about. And this is central pain or brain pain, where the fundamental problem is an increased volume control setting. Now, this pain is different in subtle ways than either nociceptive pain or nerve pain. So let's go back to the knee again. If you have pain in your knee that is occurring because your brain volume control is set too high, not because there's something wrong with your knee, but your pain in your knee is occurring because your brain volume control is set too high, I will tell you a couple characteristics of this pain. Number one, is you won't be able to localize it nearly as well as if it was coming from your knee. If I asked you to point with one finger where in your knee you hurt, you probably would draw a big circle, but you wouldn't just point with one little finger and say that it's in this exact location. The location wouldn't be nearly as consistent from hour to hour, day to day, week to week if your knee pain is coming from your brain as if it's coming from your knee. If your knee pain is coming from your brain, one day it's on this side of your knee, a week later it's on this side of your knee, and a month later it's in your other knee. Because the problem isn't in your knee, it's in the brain, and so it's not going to be in exactly the same location from hour to hour, day to day, week to week, as if you have damage in one area of your body where the pain's always going to be coming from precisely that same location. The other thing is that if you have pain that is you're feeling in your knee that is coming from your brain, you're not just going to have pain in your brain. You're going to have pain in multiple other areas of your body, because going back to my guitar analogy, if your amplifier is set too high, any of the strings, if strummed, would be louder. So the best way to determine that someone has brain pain is we give them a body map and we ask them to mark with X's all the areas of the body you have pain. And this includes headaches, this includes sore throats, this includes any kind of pain or discomfort you have. And the more X's you have on your body, the more regions of your body that you have pain in intermittently, the more likely your pain is coming from your brain, because this is the fundamental characteristic of brain pain, is it's going to be much more widespread. It's going to involve many more areas of the body than just a single area of the body where you're experiencing pain. And the best way to determine if someone has brain pain is to give them a body map and say to them, mark this body map with X's all the areas of the body that you have ever had chronic pain in your life. Or you could ask someone, mark this in all the areas of the body that you have ever had to go to a doctor because you had pain or irritation in this area of the body. Now you're going to hate me when I say this, but I'm using this as an example. So I am an incredibly pain insensitive person. I've never had a headache in my life. I've never had chronic pain in my life. I am like that person that could have a knee x-ray that looks like the one on the right and not feel anything whatsoever, because I know, based on putting myself through all the same research studies that we put research participants through, that I have a low volume control setting. I'm just fortunate. I have a low volume control setting. But when I experience acute pain, it's like this. It's very well localized. It's very consistent in location. And if you were to give me a sheet of paper that says, mark with an X all the different areas of the body that you have ever had chronic pain or that you have ever had to go to a doctor for, I'm going to give you back a blank sheet of paper. And so are more than half of the people in the population. I'm not that odd. It's only 1 out of 3 people in the population that has any type of chronic pain. And a lot of people with chronic pain have brain pain as their fundamental problem. So chronic pain chronic pain in different regions of the body very often occurs in the same individual, and that is the best marker of the fact that their pain is fundamentally coming from their brain rather than from all those different areas of the body, because the widespread nature of the pain, the multifocal nature of the pain, clues us into the fact that the brain or the amplifier is the fundamental problem. The other thing about this type of pain is you're going to have other symptoms that come from the central nervous system at the same time as you have pain in multiple areas of the body. You're going to have sleep problems, fatigue, memory problems, and mood problems along with your pain, because those are all other symptoms that come from the central nervous system and come from the same kind of brain dysfunction that we think causes the increase in the volume control setting, causes the fatigue, the sleep problems, the memory problems, the mood problems that go along with brain pain. And again, these are the poster children for brain pain, but people, 30 or 40% of people with nerve pain and 20 to 30% of people with nociceptive pain also have brain pain. So if your primary diagnosis is that you have cancer or that you have osteoarthritis or rheumatoid arthritis, you still very well might have brain pain, and that may be why your pain has not responded to the drug and non-drug treatments that you've been given, because your pain was all being treated as though it was all nociceptive pain, when in fact some of your pain was coming from this volume control setting, and that wasn't being managed. You weren't giving any drug or non-drug therapies aimed at trying to reduce your volume control. This is just another way of showing this in the same way, is that different people are at different points in this bell-shaped curve of how tender people are. How tender you are is one measure we can use of how sensitive you are throughout your entire body with respect to what your brain has done. And if you're wondering if you're tender or not, and you have never been in any of our research studies where we actually, has anyone been in any of our studies? Okay, if you come in any of our research studies, we'll smush your thumb. And by that I mean we have a little gadget that has a little rubber stopper that gently puts pressure on someone's thumbnail. And with that very light pressure, we ask them, do you have any pain in your thumbnail? And then if you say no, we'll give you a little bit more pressure and a little bit more pressure, but we'll be able to see where you are in this bell-shaped curve of pain sensitivity. And most people with chronic pain will have pain in their thumbnail with about 3 or 4 pounds of pressure on their thumbnail. They'll start to experience pain in their thumbnail. And they're over here on this bell-shaped curve. I'm over here. It takes about 18 pounds of pressure up to my thumbnail for me to experience pain in my thumbnail. But that's important, is that if it takes 18 pounds of pressure for me to experience pain in my thumbnail, then it would go without saying that I'd have to have a lot more damage in my thumbnail than you would in order to experience pain, because I'm less pain sensitive for the same amount of pressure applied to my thumb. And this is really the essence of these brain pain conditions, is that people are skewed to the right side of the bell-shaped curve. They have a higher volume control setting, and the higher their volume control setting, the more pain they're going to experience, irrespective of what's wrong with your knee. That if your volume control is high, you're going to feel stuff as pain that's just day-to-day life. That things that happen in day-to-day life will cause you pain that won't cause me pain, because we're at opposite ends of this bell-shaped curve. So if you've never had your thumb smushed, or you've never had a tender point count and you're wondering if you're tender, if it bothers you to wear tight clothing, if it bothers you when someone hugs you, if it hurts when someone inflates a blood pressure cuff, you are at the right side of the bell-shaped curve. Those are things that don't hurt people that have average pain sensitivity, and those are certainly things that don't hurt people like me that are pain insensitive. Again, we're realizing that this is a really important concept, is that where people are on this bell-shaped curve, the component of their pain that is due to that problem rather than a problem in their knee needs to be recognized and treated, because the drug and the non-drug therapies that work for your knee don't work for your brain. Now, Fred Wolf is a rheumatologist that coined this term fibromyalgia-ness, and we like this term because what it's indicating is that instead of thinking of fibromyalgia as these people that are really pain sensitive, that have pain all over, that have widespread pain, and those people have a disease, but people that have pain in like 3 or 4 areas of their body and have some fatigue and some sleep problems and don't meet criteria for fibromyalgia, don't have anything wrong with them. What Fred Wolf showed, and then our group has done a lot of research in the last 5 years or so to expand upon this, is that we shouldn't think of fibromyalgia as yes or no. We shouldn't say to a chronic pain patient, you know, you have fibromyalgia and you don't have fibromyalgia. Because fibromyalgia is sort of an arbitrary cut point to say that when someone gets to a certain level of tenderness to a certain level of volume control, we're going to call that a disease. If you have a higher than average volume control setting, then you have some fibromyalgia that is contributing to your pain, and that's a therapeutic target. So one of the things that we completely agree with is that instead of saying that fibromyalgia is yes or no, we should be saying more like, this person has like 80% fibromyalgia or 70% fibromyalgia. They don't quite meet criteria for fibromyalgia, but we can tell that a lot of their pain is coming from their brain because they have multifocal pain. They have these other symptoms like sleep problems and fatigue that we see along with it. And even though they might not quite meet criteria for fibromyalgia, we should treat them as we would a fibromyalgia patient, because the treatments for fibromyalgia are the treatments that work when the pain is coming from the brain. And so this is these are the new criteria for fibromyalgia. If you're wondering if you have fibromyalgia, fill this out and I will tell you if you have fibromyalgia or not. But again, I am not suggesting that we use this rigid criteria of yes or no, because I'll show you data in a couple minutes that show wherever someone is on this continuum, if they're on the right side of that bell-shaped curve, if they have a higher than average fibromyalgia score or volume control setting, then treating them as though they have fibromyalgia, as though their brain is causing some of the problem, will be helpful therapeutically, rather than reserving those treatments for people at the far end of the continuum that meet criteria for fibromyalgia. So these are the new fibromyalgia criteria. The first thing we ask people to do is mark with an X if they have pain in any of these body regions. And you can probably, you have this in front of you so you can read it if you can't see it. But you literally just put an X in all the areas of the body that you have pain. And you get 1 point for each X you have on this side, left side of the screen. Then you come over to the right side of the screen and we ask you, do you have fatigue? No, a little bit, a moderate amount, severe. Do you have trouble with your memory? No, a little bit, a moderate amount, severe. So you get a 0 to 3 score for how much fatigue you have, how much sleep problem you have, and how much memory problems you have. And then you get 1 point each for irritable bowel, which is pain or cramps in the abdomen, depression, or headache. So your fibromyalgia score can go from 0 to 31. 13 or greater on the score is said to be diagnostic of fibromyalgia. So did I just newly diagnose anyone with fibromyalgia? Okay. That's not what I'm trying to do. I'm trying to point out to you that a lot of your pain is probably coming from your brain, because I don't really care if you carry the term fibromyalgia as a diagnostic term. What I care is that you and the clinicians who are taking care of you understand that some or much of your pain is coming from your brain, and they need to move over to the treatments that are going to work for brain pain rather than the treatments that are going to work for knee pain. So let me show you this example so you can understand what I'm talking about. Imagine you're an orthopedic surgeon, a well-intended orthopedic surgeon. Someone comes into you with knee pain, and they have an X-ray like that person that I showed you at the beginning, that really bad-looking knee X-ray where the person has bone on bone. Are you going to operate on that person and give them a new artificial joint? Of course. You're an orthopedic surgeon. You want to make people better. They have terrible arthritis in their knee, and they hurt in their knee. What could possibly go wrong? What if that knee was in this person? Would you think operating on the knee is going to help this person? No. No. And this is the problem. And I'm showing the two ends of the continuum to make a point, because this is a classic fibromyalgia patient with pain in a lot of different areas of the body, to make a point but I think it makes a point, is that you would expect that if someone only had pain in their knee and their body map only had pain in their knee, then it's highly likely that there's a problem in their knee. If this is their body map, what's the likelihood that the knee is so bothersome that that person's going to have major surgery, go through all the rehab and things like that, and the person's going to come out on the other side like this incredibly well person, because there's a whole bunch of other stuff you didn't do anything for. That operating on the knee cannot possibly help. So this is what we're talking about here, is that the more widespread someone's pain is, the more of their pain is coming from the brain. And in fact, we have just published a whole bunch of studies in people getting knee replacement surgery or people getting a hysterectomy for pain control that show that this fibromyalgia score is an incredibly powerful predictor of who is not going to get better when they have those surgical procedures that are meant to relieve pain. Is that the higher their fibromyalgia score is, the less likely the person's going to get better if we operate on their knee or their uterus, because if your problem isn't in your knee or your uterus, operating there isn't going to make you better. And so this is the reason I show this slide all the time when I talk to physicians, is that fibromyalgia is sort of the tip of the iceberg. People that don't meet criteria for fibromyalgia, that have fibromyalgia scores of 8 or 9 or 10 or 11, don't meet criteria for fibromyalgia, and maybe their primary diagnostic label isn't anything like fibromyalgia. It's osteoarthritis or rheumatoid arthritis or something else is their primary diagnosis. Virtually none of these people are being recognized in routine clinical practice as having a problem with the volume control setting in their brain, and thus a lot of these people are continuing to be treated with drugs that work in the knee, procedures, injections that work in the knee, because no one picks up on the fact that the fundamental problem is more so in the brain or the central nervous system than it is in the knee. And this is a big problem that we have in the pain field, is to really reteach clinicians that you sort of have to add together what's going on in the knee plus what's going on in the brain volume control setting to figure out why someone's having pain. And in many individuals, you have to intervene in both places. The majority of people have something wrong, a little bit wrong in both places. So maybe you have a little something wrong with your knee and a moderately high volume control setting, that those two things together can make you have severe knee pain. And intervening at your knee would be somewhat helpful if that were the case. But if someone only intervenes in the knee and doesn't intervene in the brain, in that person that has maybe 60% brain problem and 40% a knee problem, then that person's pain is only going to get 40% better, not the other 60% better. So I'm just going to show you these studies really quickly. If you want to look through these studies, you have the slides in front of you. These are studies led by Chad Brumadu, who's an anesthesiologist here at the University of Michigan that's doing really great work in the perioperative period to show how important fibromyalgia and this concept of fibromyalgia is. And what we were interested in these studies is, does someone's fibromyalgia score predict whether they're going to get benefit from surgery meant to relieve pain? And I already sort of gave you the punchline. It's highly predictive of non-responsiveness to surgery. The other thing that it's highly predictive of, which is relevant to those of you who have chronic pain, it's highly predictive of not responding to opioids with improvement of your pain. Is that this kind of pain that is coming from your brain is not nearly as responsive to narcotics or opioids as pain that is in your knee that is coming from your knee. So if you have conditions like fibromyalgia, irritable bowel, headache, and those conditions, we generally strongly recommend against using opioids, not just because they don't work for this kind of pain, but because they actually often make people worse. And I'm going to talk for a couple minutes about opioids in particular. But one of the things that teaching points about brain pain or centralized pain is that it is inherently less responsive to procedures, which makes sense, but it is also inherently less responsive to narcotics and opioids. And these are drugs that are commonly used by people with conditions like fibromyalgia, and this sort of gets these individuals into problems because they're using drugs that don't work and may actually make the fundamental problem worse rather than better. So in this study, before knee replacement surgery or before hysterectomy, we gave people this fibromyalgia measure. I already showed you how to score this measure, that 19 of the points in this measure come from how many X's you have on the body map, and 12 points come from a 0 to 3 score for fatigue, memory problems, and sleep disturbances, and then 1 point each for these other symptoms. So you can see how you could give someone this measure and they would have a score. Well, let me just show you how impactful this score is. So the score goes from 0 to 31. For each 1 point increase in someone's fibromyalgia score, if they get their knee replaced or if they get their uterus removed, they needed 9 milligrams more of oral morphine equivalents. That's how we indicate how much opioids someone needed in the perioperative period. This is just to control their pain in the first 24 hours after their surgery. For each 1 point increase in the fibromyalgia scale, people were 25% less likely to get better with improvement of their pain. And these phenomena were linear, starting at a score of 0 and going all the way up to 18 or 20. So even people well below the level of a fibromyalgia score that would have made them qualified for the diagnosis of fibromyalgia, this fibromyalgia measure was still highly predictive of surgery non-responsiveness and opioid non-responsiveness. If we compared someone who had a fibromyalgia score of 11 to someone that had a fibromyalgia score of 5, even though neither of those people would be over the 13 level that would give them the diagnosis of fibromyalgia. So let me just show this particular slide. So these scores here, these bars are the number of people that had this fibromyalgia score. So on the bottom here, which is called the x-axis, is the person's fibromyalgia score. And these bars just indicate the number of people. We had about 600 people in this knee replacement surgery study. The number of people out of the 600 or so people that hit each of the scores. So you can see just a couple people had high scores between 25 and 30. This red line is that on the right side of the red line, people would meet criteria for fibromyalgia. 13 is the score that gives you the diagnosis of fibromyalgia. But what I want to just show you are two people that would not meet criteria for fibromyalgia. that are both on the left side of that line at 13, but how impactful different fibromyalgia scores were in predicting surgery responsiveness and opioid responsiveness in someone getting their knee replaced. So these are two different people getting their knee replaced. Neither of them has fibromyalgia. They're both on the left side of the line. But patient B has a higher fibromyalgia score than patient A. Patient B needed 90 milligrams more of oral morphine equivalents in the first 24 hours to control their pain, and was 5 times less likely to get better when we replaced his or her knee compared to patient A. These are not subtle findings. These are massive differences in treatment responsiveness that are due to where people are in this bell-shaped curve or where they are in this continuum. So this is a big thing that our group and others are out teaching people, is you really have to assess where people are on this continuum. And even if they don't meet criteria for fibromyalgia per se, they still might have the same fundamental problem as fibromyalgia patients have, and still really would benefit from using the drug and the non-drug treatments that work for fibromyalgia, rather than thinking that all of that person's pain is going to respond to drug and non-drug treatments that work out in the knee. Someone's fibromyalgia score doesn't just tell us what isn't going to work, it tells us what is going to work. The drug duloxetine or Cymbalta was shown to be effective in treating osteoarthritis and low back pain. And in fact, it was approved by the FDA for treating osteoarthritis and low back pain, even though we know Cymbalta was originally an antidepressant and it's working by increasing levels of serotonin and norepinephrine in the brain. But levels of serotonin and norepinephrine in the brain control your volume control setting. So in the people with knee pain where their knee pain was due to a brain problem, those are the people that Cymbalta works in. And this is a study in low back pain that showed that the people with low back pain that had pain in other locations other than the back were a lot more likely to respond to Cymbalta than people with low back pain that only had low back pain. So the more multifocal your pain is, the better drugs like Cymbalta and Lyrica are going to work, because those are drugs that work more so in the brain, and the less well the drugs like nonsteroidals and opioids are going to work, because again, it's just really contrasting where is the problem in the brain or in the knee, and what am I going to target with respect to my drug and non-drug therapies. Same as in rheumatoid arthritis. The drug Savella or milnacipran only worked well in the people with rheumatoid arthritis that had all their inflammation well controlled, but it was their comorbid fibromyalgia and fibromyalginess that was driving their pain, and that's the subset of people that milnacipran or Savella worked in. It didn't work in rheumatoid arthritis patients that still had a lot of active inflammation, because those people are people that, again, their pain was due to a problem in their knee, and their therapy should have been directed primarily at their knee. So every chronic pain condition is at somewhere along this continuum of where 20 or 30% of people with osteoarthritis and rheumatoid arthritis also have brain pain. Half of people with sickle cell disease or low back pain or Ehlers-Danlos syndrome also have brain pain. And most people with conditions like fibromyalgia or tension headache or temporomandibular joint disorder or irritable bowel have brain pain. But now we're realizing that some people with these conditions have either nerve damage or nociceptive pain. So you can't, the fundamental problem is we used to think that if we knew the diagnostic label that someone had, that we would know how to treat them, because everyone with that diagnostic label had the same underlying mechanism of pain. All people with fibromyalgia have brain pain. All people with osteoarthritis have knee pain. Now, though, that's all wrong. And so we have to look at each person and say, I don't really care what your diagnostic label is, whether it's osteoarthritis or rheumatoid arthritis or low back pain. What I really care about is, does your pain seem to be coming from your back, or does it seem to be coming from your brain? Because the treatments that are going to work in you, I don't care that your label is low back pain. Some people with low back pain, 95% of their pain is coming from their brain. And some people with low back pain, 95% of their brain is coming from their back, and there's everything in between. So we can't treat pain based on the label. We have to treat pain based on a more nuanced look at the person who has that label and say, in that person who has low back pain, is it coming from their brain, is it coming from their knee, or some combination of both? And I'm going to treat them accordingly. So this is the diagram I showed you before. And all I'm really trying to point out now is that these are all mixed pain states. You can't, just because the primary mechanism in osteoarthritis is nociceptive pain, the primary mechanism in diabetic neuropathic pain is nerve pain, and the primary mechanism in fibromyalgia is brain pain, is that any individual with any of these conditions can have any of the three mechanisms of pain. And so that's how we have to diagnose and treat people with chronic pain, is take a more nuanced look at them, figure out what the underlying mechanisms are that are driving this, and treat based on a better understanding of that mechanism. And we've learned a lot about the underlying cause of brain pain. Using brain imaging studies, there are a lot of objective abnormalities in people with conditions like fibromyalgia or brain pain. The notion that we don't know what is wrong with people with fibromyalgia, that there's nothing objective that we can find wrong in fibromyalgia, that's all stupid. The last 20 years, there have been scores of studies that have shown the same thing that we initially showed on the first brain imaging study that was done in fibromyalgia that was published in 2002, that the fundamental problem in fibromyalgia is this increased volume control problem, and that leads to a lot of these downstream consequences. But again, a lot of different work that's been done over the last couple decades showing the objective underpinnings of these illnesses, which has led to these conditions having increased credibility in the medical and scientific field. I mean, most people actually can utter the word fibromyalgia now. Most people know what it is. That isn't what it, for any of you who have had the label of fibromyalgia for 20 or 30 years, you know how far fibromyalgia has come in the last couple decades with respect to acceptance. Is it where it should be? No. There would be random physicians and healthcare providers that look at you when you're cross-eyed when you say you have something like fibromyalgia, but it's infinitely better than it was 10 years ago or 20 years ago, and it's getting a lot better as we train more and more people with a fundamental different understanding of what's causing chronic pain. These are, again, I'm just going to show you very rapidly, these are just some of the types of research studies that have been done to show this increased volume control setting. These are all studies that were done by our group. This is the first functional MRI study done in fibromyalgia. And all we really showed is that when fibromyalgia patients say they hurt, when we apply a low pressure stimulus to their thumbnail that wouldn't hurt a non-fibromyalgia patient, we could actually see that their brain was experiencing pain. We could see objective evidence that they were experiencing pain even though we were only applying light pressure, because we could see that the regions of the brain that are activated when someone is in pain were all activated in the fibromyalgia patients getting that light pressure, but not in the controls getting that same amount of pressure. So it was a really expensive study that just showed that there was this increased volume control or increased gain setting in people with fibromyalgia. Since then, there's all sorts of different research techniques that show that different brain regions are too connected to each other or not connected enough to each other. This is now a lot of medical conditions that are in the brain couldn't really be objectively diagnosed until the advent of some of these techniques like brain imaging. So it's not a surprise that we're finally able to legitimize conditions like fibromyalgia, because it wasn't until the advent of these research techniques that we finally had techniques that we could see how the brain was functioning in a living, awake human being. I mean, we can't biopsy the brain or do things to the brain that we do to other organs or other parts of the body. When your brain is involved in pain, it even changes in size and shape. If people who have brain pain, most of the brain regions actually shrink in people with brain pain. The only brain region that gets bigger in people with brain pain is the brain region called the primary somatosensory cortex, which is the brain region that helps tell you where your pain is. That region actually gets larger because your brain's trying to be able to tell where all this pain that's coming from different areas of your body is coming from. So it increases the size of that brain region, whereas it decreases the size of all the other brain regions because it's trying to reduce the amount of pain that you're experiencing. So this isn't just an academic problem, because the drugs that work to treat brain pain are entirely different than the drugs that work to treat knee pain. Here's the drugs that we use to treat knee pain: opioids, nonsteroidal anti-inflammatory drugs, corticosteroids can all be used if there's damage or inflammation in the knee. These don't work at all if the person's problem is in the brain or is a fundamental amplifier problem. Now, what I'm going to do is I'm going to talk very briefly about drugs, but I'm not going to talk very long because most of you don't have a background in pharmacology. I am going to highly recommend that if you want to talk to your treating physicians or healthcare providers about trying new drugs for your pain, I'm going to strongly recommend that what you do is you tear out this review article on fibromyalgia that I wrote a couple years ago in JAMA, and you take this to your physician. A couple reasons that I'm recommending you do this. Number one is that this JAMA is a medical journal that any physician will find to be a credible source of information. This will be infinitely better received than if you print something off the internet on fibromyalgia and bring it to your physician. But the other reason, and it's not just because I wrote the article, the other reason that I think this article is really helpful is JAMA actually came to me and asked me to write a review article that was the equivalent to sort of fibromyalgia for dummies, but basically so that people that don't understand fibromyalgia can treat fibromyalgia. And this table in this article goes through and lists every drug and non-drug therapy that is known to be effective in fibromyalgia. But if, as a result of sitting through this lecture today, you have concluded that some of your pain is coming from your brain, you need to try these drug and non-drug treatments. These are the things that are more likely to work in you, at least for that component of your pain, than the things you have been trying. The reason I'm not going to spend a lot of time talking about these things now is that there's a lot of detail in this table about the dose to start at, the side effect profile, how to give these drugs so that they're better tolerated and people can tolerate them. And again, this would in general be a bit over the head of most lay people that don't have an understanding of the pharmacology of drugs. So what I would suggest that you do is take this article, and especially this table, to one of the healthcare providers who's been working with you that really is helping manage your pain, and just talk to them about trying some of these drug or non-drug therapies, because these may very well be the types of therapies, because they're directed towards the brain, that would be more helpful in you than the therapies that you've been getting historically. It talks about all of the side effects of the drugs, and this is a big problem with all of our drugs, is they do have side effects. All right. Really quickly, let me just talk about some of the classes of drugs that can be helpful, and this also will allow me to talk about two specific classes of drugs, opioids and medical marijuana or cannabis. So first, these drugs here. When I point to the drug, I will tell you what the brand name is, because you're a lot more likely to know the brand name than the generic names that are on the slides. This is Elavil. This is Flexeril. Let me stop at Flexeril. If you have brain pain and you haven't ever tried taking a low nighttime dose of Flexeril for your brain pain, you should. It is my favorite drug for conditions like fibromyalgia. By low nighttime dose, almost all of you have probably been prescribed Flexeril as a muscle relaxant. When it's given as a muscle relaxant, it's given 10 milligrams every 6 hours. That is not at all how we recommend people take it when they have brain pain or fibromyalgia. They'll take 5 or 10 milligrams 2 to 3 hours before bedtime, slowly increase the dose. The reason I like Flexeril, number one, is it's incredibly cheap. It's been on the market for about 40 years, so it's extremely inexpensive. Number two, it doesn't have a lot of drug interactions with other drugs. And number three, it actually, if it works in you, it helps a lot of symptoms other than pain. In addition to it helping pain, it can help with sleep. That's why we give it a couple hours before bedtime. It can help with a lot of the other symptoms that people have in the setting of centralized pain or fibromyalgia. Next class of drugs, these drugs are all similar to each other. Savella, Cymbalta, Effexor. Savella and Cymbalta are approved for use in fibromyalgia. The trick with these drugs is a lot of people take these drugs for a couple days, and because they're so nauseated or vomiting, they stop taking the drug. If that happened to you, try these drugs again, starting at a really low dose, going up very slowly and taking them with food, and understanding that the nausea and vomiting that occurs with drugs like Cymbalta or Savella typically goes away after about 7 to 10 days. So one of the problems with these drugs is there's a tremendous number of people that have chronic pain that were given one of these drugs, but were not told how to start at a low dose, take it with food, everything that I just said. And so when they come in and see us, they say, I failed Cymbalta or I failed Savella. It's like, well, You didn't really fail it, you just weren't prescribed it in the manner in which you would tolerate it the best. And so I'm not sure that you really failed it. The same thing would be true of this next class of drugs, which is Lyrica or Neurontin. We very commonly will have people come in and say, I tried Lyrica or I tried Neurontin and it didn't work in me. And then I'll ask them, well, what dose did you get up to? And they'll say, well, I got up to 600 milligrams of Neurontin. And I say, well, Neurontin doesn't ever really work until you get up to 1,800 milligrams. 600 milligrams of Neurontin is just simply not enough Neurontin. Or Lyrica, similarly, people are on 50 milligrams of Lyrica and they don't respond, so someone declares, you didn't respond to Lyrica. One problem with these drugs is that people don't get up to a high enough dose for them to work. Another problem is people are not told as patients that if you take the entirety of your Lyrica dose or your Neurontin dose at bedtime, or 2/3 of the dose at bedtime, it'll be way better tolerated than if you take equal amounts 3 times a day, which is how it's often prescribed. So any pain specialist that's been taking care of a lot of pain patients will give Neurontin or Lyrica the majority of the dose at bedtime, because we want you to be sedated from the Lyrica. The sleep that Lyrica induces is deep sleep and actually helps improve your pain. Part of how it works is by making you sleep deeply. So we want you to take a higher percentage of Lyrica or Neurontin at bedtime so that you're sedated and you get that deep sleep. Whereas if you take that equal amounts of that drug 3 times a day, it's going to cause you to be drowsy during the day, rather than at night when we want you to be drowsy and we want you to sleep. So these are just subtle things that are in that JAMA article. It's not just what drug to give, but it's how to start, what dose to start out at, and gives the physicians and other healthcare providers helpful hints about these drugs and when and where to use them. So a couple other drugs. Tramadol or Ultram is an okay drug. I'm not a big fan of Ultram just because it doesn't work that well in that many people, but it's not a bad as-needed drug for a lot of people with brain pain. Older serotonin reuptake inhibitors like Prozac, Zoloft, Paxil can be helpful to treat brain pain, but you have to go to higher dosages than the antidepressant dose. And again, that's in that JAMA article. So if you're on a drug like Prozac, Zoloft, or Paxil as your antidepressant drug, and you are wanting to see if that drug might in fact help your pain, you may want to go to your physician and see if he or she would prescribe a higher dose, which would be needed to treat pain, than the lower dose that's needed to treat depression. Gamma hydroxybutyrate is a drug that worked really well in clinical trials of fibromyalgia, but it is GHB, which is the date rape drug. So it was not approved by the FDA for use in fibromyalgia, but GHB is available as a drug to treat certain types of sleep disorders. And if you have fibromyalgia, you almost always have sleep disorders. So you may find a sleep specialist that's willing to prescribe GHB for the sleep problem you have, and that might very well help the fibromyalgia and the pain problem you have. So it's appropriately on the chart, but it's not FDA approved, and most physicians won't prescribe it for use in. You have to actually go to special classes to prescribe GHB because of all the concerns about diversion for GHB. So I, for example, don't prescribe GHB. I'll talk about medical marijuana or cannabinoids in just a second. Low-dose naltrexone is an interesting story. Anyone know what naltrexone does? So naltrexone is the oral version of naloxone. Anyone know what naloxone does? You probably heard this in the press. Naloxone is the drug that antagonizes opioids. So when someone is having an opioid overdose and they stop breathing, you inject them with naloxone. Naltrexone is the oral version of that. And oral naltrexone, which is blocking the body's own internal opioid receptors, has been shown in 2 different studies to be effective in fibromyalgia. Let me make sure you understand this. This is, instead of giving someone an opioid, which is what we would think you would do if someone has chronic pain, that actually blocking the body's own internal opioid system might be helpful in fibromyalgia. And we have done brain imaging studies that show why that might be the case. We have shown in a series of brain imaging studies that when people have this kind of pain, brain pain and fibromyalgia pain, their body's own opioid system is releasing a lot of endorphins and enkephalins. Endorphins and enkephalins are the body's own opioids that you release yourself and bind to your opioid receptors. They bind to the same opioid receptors that if you gave someone morphine or Percocet or OxyContin or heroin, that drug would bind to. And what we've shown in people with fibromyalgia is that the body is releasing so many of its own opioids that all those opioid receptors in the brain are bound up by the body's own opioids. And so when you give that person a opioid drug, there's nowhere for it to work. Those opioid receptors are already being occupied or bound by the person's own opioids they're releasing. And this is why blocking the opioid system rather than giving someone opioids might be the right thing to do for people with this kind of pain.